Hello, everyone, and welcome to Ostomy Canada Society's national webinar today. We're really excited to have people joining us from coast to coast to coast, and we have a great topic for you today. My name's Troy, and I'm on the board of directors for Ostomy Canada Society, and I'm happy to help introduce this topic with you. Our topic for today is going to be preventing and managing peristomal skin complications, and we have a wonderful presenter today named Tarik Alam. Before I introduce Tarik and get into our presentation, I just wanted to go through a couple housekeeping items. Firstly, we will be having a question and answer portion at the end of this presentation, and I want to thank everybody who did submit their questions in advance. It's really appreciated. We're going to get to as many of those as we can, as well as the questions that you can submit throughout the duration of this presentation. You'll see that in your toolbar on Microsoft Live Events, you have the option to use the Q&A function. That Q&A function will allow you to post a question that both myself and Tarik will be able to see, and we'll be happy to answer that later on. So as I mentioned, today's topic is on preventing and managing peristomal skin complications, and we hope today to describe factors that affect skin health under the ostomy barrier, list different types of peristomal skin complications, and discuss strategies to prevent and manage peristomal skin complications. So I'm happy to welcome Tarik Alam, and Tarik began his nursing career as a registered nurse in acute medicine and surgery at the McGill University Health Center in Montreal, Quebec. Tarik joined Hollister Canada in 2008 and presently works as the Clinical Affairs Manager. He is a former Adjunct Clinical Professor at the University of Western Ontario in the Wound Healing Program and lectures at John Abbott and Dawson College in Montreal. He's also working occasionally as a nurse clinician in Montreal as vaccinator in clinics. And so before I pass it over to Tarik, I just want to remind everybody that while Ostomy Canada and our guest presenters will do our best to help answer each of your questions, any questions requiring a healthcare professional to perform an assessment via telehealth or in person should instead be directed to our Medical Lifestyle Advisory Committee. We also encourage you to reach out to your physician and/or an NSWOC in your area for further questions that can't be answered during this webinar. Note as well that any recommendations made during this webinar are not intended to be a substitute for seeking professional advice, guidance, and/or treatment. So without further ado, it is my pleasure to welcome Tarik Alam. Thanks, Tarik.
Thank you so much, Troy, and thank you to Ostomy Canada Society for inviting me to speak to you today. And above and beyond everything, thank you to all the participants who are attending this session today. The learning objectives for this session will be to describe certain factors that affect the skin health under your ostomy barrier, look at the different types of peristomal skin complications, and also discuss strategies to prevent and manage peristomal skin complications. Here are some of my disclosures. I am a clinical affairs manager for a company that makes or manufactures ostomy products. That's Hollister Limited. And I'd also like to thank Deborah Abner, who is a nurse specialized in wound ostomy and incontinence, and my former partner in clinical practice, for assistance on this presentation for some ideas and materials. You know, my lifelong journey in ostomy care has spanned over 25 years. When I was in nursing school about 30 years ago, I became very interested in ostomy management because I ended up working with a nurse who specialized in ostomy management, Kathy Foster at the time, and she was very passionate about what she did. And that changed the course of my career, because after nursing school, I eventually became specialized as an enterostomal therapy nurse, now known as a nurse specialized in wound ostomy and incontinence. And currently, for the past 20 years, I've had the pleasure of teaching at Dawson College in the Department of Nursing, just one lecture a semester, and that's the ostomy lecture. And that's where I get to work with the staff and students and keep them updated on the latest information about how to manage an ostomy and how to keep the peristomal skin health in best of shape. I've also lectured for a couple of societies and groups such as Bladder Care Cancer, and I do occasionally work in long-term care or give vaccinations. And that's a picture of me working in long-term care. I don't use the stethoscope for ostomy management, but occasionally I was looking after some of the clients as a staff nurse. Just a comment, there's many companies that offer ostomy products and services. There will be no promotion of any particular ostomy company or brand, and I will use various pictures of products from different ostomy companies throughout the lecture. Troy has covered some of this, but again, the information in this webinar is simply to provide you with information as a resource, and it's not to be used for medical advice. It's strongly recommended that you do contact your healthcare professional about any specific medical condition. And Troy has also covered this in his statement. And keep in mind that if you have any questions, you can direct them through the website of Ostomy Canada Society, to the Medical Lifestyle Advisory Committee. So that's a great resource to have. And thank you, Ostomy Canada Society, for providing this resource. We may come from different backgrounds and have different experiences relating to having an ostomy or knowing someone with an ostomy. So I'll start off with a couple of basic concepts just so we can become familiar with some of the terms that I may use. An ostomy and stoma are words that can be used interchangeably. In addition, I'll talk about different types of ostomies or stomas, but there are three types of ostomies that people can have. One can be a colostomy, where the ostomy is made on the large intestine. And in this case, the fecal matter or the bowel movement is more formed in most cases. Whereas someone with an ileostomy made on the small intestine, the bowel movement is more pasty or sometimes a little on the liquid side. And someone with a urostomy, where urine will come out of the ostomy, of course, this is liquid. So why would I mention these three types? Well, we do see that there's more risk of peristomal skin complications when the output is liquid or semi-liquid, such as from an ileostomy or urostomy. And we do know that from some of the research that has been published on ostomy management. Another point of interest is, what kind of ostomy does one have? Is it an endostomy or a loopostomy? An endostomy has one opening, and this is often done for a permanent type ostomy. For example, you may have a colostomy, ileostomy, or even a urostomy that just has one opening. In some cases, a surgeon may do what's called a loopostomy, and a loopostomy is typically done on an ileostomy. It may be done on a colostomy, but we see it much more often on an ileostomy, and that's where there are two openings on the ostomy. And this is done usually because it's a temporary ostomy, and it can be closed or what we call reversed at a later time. The reason why I mention that is that from one of the openings, there will be bowel movement which will come out, and the other opening, there may be a bit of mucus that will come out, but we don't normally see that because it gets mixed in with the bowel movement. The reason I mention this, again, is that people with a loopostomy are more at risk of developing peristomal skin complications because the overall ostomy usually does not stick out as much as a typical endostomy. Keep in mind that all ostomies can either stick out or even be at skin level or even below the skin in some cases. But typically we do know that a loop ileostomy will stick out less than an endostomy, and this just creates the potential for more chance that the bowel movement may leak under the ostomy skin barrier and cause peristomal skin complications. When we're looking at the typical ostomy equipment that's available for purchase in the Canadian market, we typically have different kinds of ostomy barriers or skin barriers. And there's other names for that. Some people will call it the ostomy flange or the ostomy wafer. I'll refer it to simply as the ostomy barrier, and that really refers to the part that sticks to your skin. Sometimes we can have the barrier and the pouch all as a one-piece system, which can be used by some people. And of course, there's different kind of pouches available. When we look at the ostomy barrier types, we see different types of barriers. That's the part that sticks to the skin. The barriers can be flat, with or without a tape border, or they can be what we call convex. In other words, the barrier actually has a bump on it, and you can see that in the images on the right. And the purpose of having the convex shape or the bump is that if someone has some skin folds, or if the stoma is not protruding or a little bit recessed, in other words, at skin level or a little bit in, the convexity, the bump, will try to press around the ostomy on the skin and try to push the stoma out, so the bowel movement or the urine enters the pouching system and has less chance of going under the barrier onto the skin. There is another kind of flat barrier. It's called the concave barrier. It's simply flat, but it can conform to rounded surfaces, just like an ordinary flat barrier can. So those are the types of different barriers. It's important to know that these barriers are made with materials that are, one, meant to adhere to the skin, to protect the skin, but also, and more importantly, three, is to absorb small amounts of moisture which comes out of our skin. Think of this: if we take saran wrap, which is pretty much completely waterproof, it's not breathable, and if we wrap that around our arm, what will happen over a period of time is eventually the moisture coming out of the skin will be trapped between the skin and the saran wrap, and that will lead to skin breakdown. We'll get what we call maceration. It's kind of like when you're in the bathtub and you have a Band-Aid on your finger and you take it off. You know, you've been in the bathtub for too long, you get out of the bathtub and then you take off the Band-Aid the next day and it's all whitish. That's called maceration. So these ostomy barriers are really meant to stay in place, but also absorb small amounts of moisture from the skin. Ideally, if you're having ostomy surgery, or for any management after, or questions or follow-up for your ostomy, you can see what we call a specialist called a nurse specialized in wound ostomy and continence, which is a registered nurse who has advanced knowledge in ostomy and wound incontinence. The name prior to this name change was called an enterostomal therapy nurse. So some of us may still see that term being used, ET nurse or enterostomal therapy nurse. But the organization is the Nurses Specialized in Wound Ostomy and Continence Canada, and that's an organization that oversees the membership. And there's about 700 NSWOC nurses in Canada. Keep in mind there may be other healthcare professionals that may be involved in the care of an ostomy, such as other types of nurses. If you don't have access to an NSWOC nurse and you need to get in touch with one, you may actually try going onto the Ostomy Canada Society webpage, and there's a link where you can find an NSWOC nurse. So if you don't have one, that is one way to find an NSWOC nurse. When we're talking about the skin under the ostomy barrier, remember this: healthy skin should be the rule and not the exception. We do know that the peristomal skin is really, in terms of how we're describing it, it's the skin under the barrier that is covered by the ostomy barrier when it's in place. And the peristomal skin should always look like the skin on the rest of your abdomen. And in the picture on the top, you can see the ostomy with the peristomal skin being completely intact. In other words, it looks like the skin on the other side of the abdomen where the gentleman is pointing to. Because if there's any redness or irritation, that is considered abnormal and should be dealt with, because if there's skin irritation or skin breakdown, it may tend to get worse. We have to realize that if we have a peristomal skin problem or irritation or breakdown, we can't just leave the ostomy barrier off the skin for a day or two, because what will happen is the bowel movement or urine, of course, will spill onto the skin and likely cause further damage. So we really need to prevent these if we can, and when they start to happen, we need to deal with them in a really quick way to avoid getting worse complications. If we look at the research, and there is quite a bit of research being done on ostomy management, because there are many people both in Canada and worldwide who have an ostomy. And we do know that the peristomal skin is generally considered that skin that's covered by the barrier. And we know that peristomal skin should always be intact, again, looking like the skin on the other side of the abdomen, and really should be free of any redness or signs of skin breakdown. Itchiness is an interesting one. Some people may start to feel a bit of itchiness, and that can be an indicator that you may want to consider removing the barrier and looking at your skin. There may be a bit of leakage, which is starting to cause a bit of itchiness, and that should be looked at as soon as possible. When we look at healthy versus damaged peristomal skin, here are two pictures that illustrate that. The ostomy on the left-hand side that we've seen before has intact peristomal skin, but on the right, the skin is damaged and irritated. And this will continue to worsen if something isn't done to alleviate the situation. Here are some peristomal skin examples. There's 3 cases here, and I'll go through them. But essentially, in the literature, we do know that when there is redness, or what we call skin inflammation or damage, and that it occurs around or under the barrier, that's what we consider some type of peristomal skin complication. So the term peristomal skin complication is a general term which encompasses any abnormality of the skin or tissue under the barrier or immediately adjacent or next to the barrier. And in the first image on the left, we can see that the skin is irritated. And this may happen if the opening of the barrier is too large or it doesn't stick very well. The drainage from the stoma can damage the skin. And in this case, remeasuring the size and making the opening the same size as the stoma and applying it in a certain way, we'll look at that in a couple of minutes, usually will help resolve the redness. If the skin is broken, we can use something called powder. We'll see that in a little bit. But if the skin is just red and not broken, simply removing the barrier, cleansing the skin, drying the skin, and re-measuring the ostomy is usually the best course of action. If we look at the middle image, we see that the peristomal skin is now reddened and also broken, and that irritation in this case is due to persistent leakage. And in this case, if someone has feeling on the abdomen, which most of us would have, they would feel perhaps some burning or itching or stinging sensation. And in this case, the barrier should be removed to see what's going on under there. And if the skin is just red, resizing can work well, but if the redness continues to increase, we really suggest that you consult your healthcare professional, ideally your NSWOC nurse. And there may be different things that can be done. We'll look at a couple of those in a little while. If we look on the right, we see that in this case, there's an even rash under the entire area of the ostomy barrier. And sometimes a rash can be caused by different means like infection or sensitivity to an ostomy barrier. And in this case, it's really important to get assistance from your healthcare professional, really your NSWOC nurse, to see what is causing this even redness. And there's different things that can be done, different products that can be used, or different approaches. And that's really important to contact your NSWOC nurse or healthcare professional. When we look at what really causes peristomal skin complications, let's take a look. For the most part, we want the skin, the peristomal skin, to be healthy and intact and free of any sign of skin damage. But in some cases, leakage may occur, and this causes poor adherence or stickiness of the barrier to the skin. And so the liquid output or the fecal output will go between the barrier and the skin and start breaking down the skin. In other cases, keep in mind that these ostomy barriers, they are adhesive in nature. Whether it has a tape border or not, they're all adhesives. They're specially formulated for the skin, but they have the potential to cause skin damage if not used in an optimal way. For example, if one would aggressively rip off the ostomy barrier, you're likely going to, or you may cause some skin damage, which will tend to worsen with time if that's not addressed. And that's what we call mechanical trauma or injury. So these two things, moisture such as leakage and trauma, or physical damage to the skin, are the two major causes of skin damage, which will affect the ability of the ostomy barrier to stick to your skin. And what will that do? That will affect the healthy skin. So what is the impact of having these peristomal skin complications? Well, we do know that leakage is a problem because you may have to change the barrier at a higher frequency, like more often, and of course that's more costly. Just having irritation and itching is uncomfortable, and prolonged peristomal skin complications actually may affect one's quality of life, and we'll take a look at that in a couple of minutes. Also, if there's leakage, there may be unpleasant odors or staining on one's clothes or other surfaces, and that is unpleasant. But my overall point is it affects one's quality of life. There's a risk for skin complications, and of course, the overall cost of caring for your ostomy will go up. When we look at the problem of peristomal skin complications, what the research has found is that up to 3/4 of the people with an ostomy, or 75%, may have peristomal skin complications, at a certain point in time. So that's quite a bit. That's really 3 out of 4 people. And interestingly enough, we do know that these complications affect one's quality of life, and not only raises the cost of care, but interestingly enough, not everyone who has peristomal skin complications will go seek assistance or help. So how do we break the cycle of these peristomal skin complications? Well, there's 2 things that cause peristomal skin complications for the majority of the time, and that is really either leakage of the contents from the ostomy onto the skin, in between the barrier and the skin. That will cause problems, and in this case, that's usually due to perhaps the barrier not being the optimal size for the ostomy, or just the skin barrier perhaps not being applied. Perhaps it's not the optimal type of barrier that will fit someone's abdomen or shape of abdomen. Also, the other cause is simply damage caused by the adhesive. And again, if we remove the barrier too aggressively, we may have some types of skin stripping type injuries. And so medical terms, there are actually, medical terminology for the skin damage. When you have damage caused by moisture, it's really called peristomal moisture associated skin damage, or PMASD. The other term is when you have damage that is thought to be due to the adhesive nature of the barrier. In other words, if one would remove the barrier very aggressively, that's called peristomal medical adhesive related skin injury, or PMARC. Those are medical terms, but I thought it may be interesting to mention them because if you do Google searches or other types of searches, you may encounter this terminology, which is fairly on the new side and being used much more in the literature for ostomy research and documentation. So when we look at the major causes of peristomal skin damage, again, we see problems caused by 1, moisture, such as in peristomal moisture associated skin damage; 2, mechanical trauma or damage, that's peristomal medical adhesive related skin injury, or PMARC. And the third reason can be due to other causes. So I would say most of us in the healthcare profession or NSWOC community would agree that the vast majority of peristomal skin breakdowns are due to moisture or trauma. But there are other causes, and we'll look at those throughout the presentation. I want to highlight that prevention is really the key to tackling and preventing peristomal skin complications, because if your skin is irritated or damaged, it can be simply uncomfortable and painful. In addition, the peristomal skin issues can weaken the ability of your skin barrier to remain in place, and your ostomy pouching system may not be secure. And that's why taking care of the skin is so important. There's a couple of things that may help you. Take the peristomal skin health seriously. If you see something, redness or irritation, try to address this as quickly as you can. And if things are getting worsening despite what you're doing, be sure to contact your NSWOC nurse or other healthcare professional. It's important to use the proper size opening. If one uses an opening on the barrier too large, it allows the output, in other words, the fecal material of the urine, to be in contact with the intact skin or the skin, and that may lead to skin breakdown. It's recommended that one change their pouching system, in other words, the skin barrier, on a regular basis to prevent problems. On average, people will change their barrier every 3 to 4 days. We understand that some people are able to keep the barrier in for perhaps up to 7 days, and their skin is always healthy. And we commonly will see that when there's less liquid output, such as someone with a colostomy. Although people with an ileostomy can get upwards of a couple more days wear time, 5, 6, 7 days in some cases. But on average, people change their barrier about twice a week. If you experience itching, it's important to remove it and take a look at the skin. And keep in mind, be very gentle with the barrier removal. When the barrier is being removed, it's important to avoid any kind of damage. If you're having challenges finding the right product, you may contact some ostomy manufacturers, customer service, and some of their support programs can be very practical and useful. And also, keep in mind that always feel free to reach out to your NSWOC nurse if you have, problems or you're having challenges with the products. Let's start off at the beginning and go through how to change a barrier to minimize the chance of injuring the skin and preventing peristomal skin complications as a result of perhaps leakage. So the first thing is, when the pouching system is ready to be removed, one can empty the pouch first and then get all the equipment ready, and then start removing the barrier from top to bottom, slowly pulling away the barrier with one hand and supporting the skin with the other. And this helps separate the barrier from the skin. If one goes too aggressively or pulls it at a very high angle, it may actually put a bit too much tension and increase the risk of skin damage. Adhesive remover wipes can be used and are very, very practical to separate the skin barrier from the skin, and that can help in some people minimize or avoid skin damage by using an adhesive remover wipe. And these are available from different manufacturers. Once the barrier has been removed, simply clean the peristomal skin with warm water. That is quite easily done. One does not necessarily need to use soaps, and some soaps that leave a residue or a film are problematic because if left on the skin, they may interfere with the barrier adhesion. So warm water can be used, and if there's still adhesive residue once you've dried the skin, simply use an adhesive remover. These adhesive removers from ostomy companies generally don't have any alcohol, so they don't sting and they don't tend to cause skin irritation. Check the condition of the skin. If you see any skin breakdown, note that and take some action about that. Once you have removed the barrier, if you need to remeasure your ostomy, what you can do is, it's always best to change the ostomy system when one is sitting or standing and not lying down. And the reason why is, if one's lying down, we don't really see very well the abdomen. And two, what happens is when a person is lying down and they place an adhesive barrier on their skin, such as an ostomy barrier, if it's placed in a lying position and one sits up, sometimes what happens is there'll be some pulling and little folds may develop. So it's always best to change the appliance when you're sitting or standing. And if someone is changing the appliance for you, you're always still better sitting upright, or standing even, but sitting upright is perfect. When you go to measure the stoma, what you can do is you can actually take your hand and put it a couple of inches above your stoma and put it on your hand on the skin and gently pull up, not aggressively, just gently. What this does is it may remove some minor folds, may tighten the skin up a little bit, and then at that point, measure the size of the stoma, whether it's round or oval. And at that point, that's the size and shape you want to choose for your barrier opening. And keep in mind, if your ostomy is round, you may be able to go with a pre-cut barrier. And if it's oval in general, one would need to cut it out. So whatever the size is, choose the size, correct size barrier, whether it's pre-cut or if you have to cut it. And then once you're all ready, you can remove the backing. Some people will use different material to fill in uneven areas or creases around the ostomy. And in this case, people will commonly use, paste barrier rings, or different products to kind of fill in uneven areas of the skin. There's a lot of different accessory type material that can be used to fill in uneven areas or to help push the stoma out to prevent leakage if it's not sticking out. And there's different types of ostomy barriers like convex barriers, and there's different kind of accessory products like the barrier rings or other types of products. But once you're applying the barrier, ensure that you're sitting up, and when you're applying the barrier to the skin, pull up the skin a little bit as you place the barrier on and apply the barrier. You really want to make the opening the same size as the ostomy and not leave skin showing around the edges between the ostomy and the barrier, because if you can see skin, that skin can potentially get irritated, and simply replace the pouch. There was an excellent question in the questions that were sent in ahead of the webinar, and one of the questions was, sometimes if I see skin bubbles under the barrier, is that a problematic, and what is that caused for? Well, there can be different causes. I mean, someone with perhaps a severe allergic reaction can develop that, but that is very, very rare. However, most commonly what we see is skin damage. If you're seeing bubbling, it's usually related to tension. For example, if someone places their barrier in a lying position and then sits up and their abdomen really bulges out and becomes a lot larger, what happens is that the skin is pulled horizontally kind of against the barrier. The skin goes one way and the barrier goes the other way, and that skin gets damaged and tends to bubble. And that's a sign of skin damage. So to avoid that, if that is what is happening, what one may do is try applying the barrier in a sitting position, and that will be the most optimal way, as we talked about changing the barrier. But you can see some damage. Sometimes if someone's abdomen swells, it'll pull against the barrier and may cause some damage. One of the most common causes of peristomal skin complications is really just being irritated from moisture leaking onto the skin, and that's called irritant contact dermatitis, or peristomal moisture associated skin damage, PMASD, as we talked about before. Some different terms, but they really mean the same thing. And in this case, what we see in the bottom right, right here where the red circle is, that the ostomy barrier opening has been cut much larger than the actual size of the ostomy. So what's happened is that the bowel movement has remained in contact with the skin, and that will soon irritate the skin. The skin will first become red, and then what will happen is after that, if we don't remove the source of the damage, it will become more and more damage, and the skin will break, and that condition will worsen. So we really want to avoid that by properly sizing the opening to the size of your stoma. And in the picture on the right, we can see that actually some of the bowel movement has actually leaked under the barrier and is now creeping its way to the edge of the barrier. In this case, the person will likely, if they have feeling there, will feel some kind of burning or itching. And if anyone feels burning or itching under the barrier, it's really recommended to remove it from top to bottom and look at the barrier as you're removing it to see where the leakage is and if there is leakage. Because if you're consistently seeing leakage at one area, there may be something that can be done, such as adding some kind of extra barrier material, such as a part of a barrier ring, to kind of caulk and fill in that area to prevent that leakage from happening. What could we do about this kind of irritation? If the area of the skin is just reddened, and that's in lighter skin people. If someone with darker type skin, such as myself, has an ostomy, sometimes it's a little harder to see that skin discoloration when there's early signs of skin irritation, redness. It may be just different colors from the rest of the skin. So keep that in mind. But when we do see skin that is kind of irritated but intact, in other words, not broken, just resizing the barrier and reapplying it is usually adequate, because you want to take off the irritation due to the leakage. But if the skin is broken now, the problem is, think of it, you've got broken skin and moisture is emitted through broken skin. And in this case, what happens is the barrier may not adhere well to that broken areas of the skin because it's wet and weepy and the barrier has to stick to something dry. So one can apply small amounts of powder, remove the excess with a Kleenex, and what you'll see is the powder actually will stick to the area where the skin is broken, and then remove the excess powder and then just simply reapply your barrier with any accessory products if you're using them, and hold that barrier in place, for a minute or two, and with the warmth of your hand and the body, that barrier will start to adhere, even if there's small amounts of powder left on that opening or that broken skin. Some types of skin damage can happen when the skin is chronically exposed to moisture, such as fecal matter or urinary output, such as urine. Typically, if someone has intact skin and starts to have leakage problems onto the skin, typically what we'll see is minor skin irritation. For example, a bit of redness in a light skinned person, and it could be different colored areas if someone has darker skin. But once that happens, if one doesn't address that leakage, the persistent leakage will now start to cause skin damage. So the top layer of the skin, the epidermis, will start to get broken, and then the skin or the tissue under it now will continue to get irritated and in worse shape. And sometimes what happens is the skin, when it's constantly being irritated and attacked by, let's say liquid or fecal matter over a long period of time, it's not only damaged, but it tends to kind of overgrow in response to the injury, the persistent injury. And that's why sometimes when someone has persistent leakage and they have lesions or lumps or different areas of skin that are now raised around the ostomy and broken, that can be due to persistent long-standing irritation. So we really want to avoid that. And in this case, the best course of action is to choose the barrier opening and the specific type of barrier and accessory products that will help avoid this problem. Pseudoverrucous lesions are really managed simply by, again, resizing the barrier. And sometimes if the lesions are really raised, some healthcare professionals may choose to use something to kind of burn down the overgrown tissue, such as what we call with silver nitrate sticks. They're little sticks that when you touch broken skin, it tends to kind of cauterize or burn it a little bit to help reduce, that overgrowth. But when that's applied, there's a bit of a stinging or burning sensation. And these are applied usually by the healthcare professional or the NSWOC nurse. And in severe cases, when there's a lot of skin breakdown and tissue damage, your NSWOC nurse or healthcare professional may actually choose to use a wound type of dressing that's appropriate and can be used under an ostomy barrier. If someone has a urostomy and there's persistent leakage, and this is a pretty extreme case, this was one of the cases that we published in a journal, a medical journal, many years ago with some of the surgeons when I was at McGill University, was that we had some people with a urostomy who had persistent leakage, and unfortunately, this often happened in people who didn't have any money or reimbursement of the funds to purchase, the barriers 2 to 3 times a week, to change it on a regular basis. And unfortunately, in some cases, the persistent leakage would chronically kind of affect and damage the skin repeatedly, and that skin tends to grow, as a defense mechanism. And unfortunately, this was a urostomy. You can't really see the urostomy anymore. What you see is this was a dark-skinned individual, and the ostomy is literally covered in overgrowth of tissue, which occurred over a period of 2 or 3 years. And this was really problematic because the opening of the stoma you could barely see it, and the urine had a bit of a hard time going through the opening. So this is an extreme case, but we really want to avoid this type of problem. And in this case, the management approach is really one may use vinegar soaks for 20 minutes between the barrier changes, getting a better barrier seal, and sometimes having it looked at by one of the physicians or surgeons along with the NSWOC nurse. We've talked about skin stripping injury, which is a peristomal skin complication, and which is not rare. It's one of the things we see more frequently, and that really is a result of barrier removal in most cases. So it's really important to remove the barrier, in a fashion that minimizes the skin damage. Slowly going from top to bottom, let's say, or undoing the edges very slowly, and considering the use of an adhesive remover. Keep in mind, as we age, our skin gets more and more fragile. So some people become more and more at risk, of skin damage. Some questions were asked previously about can we use, skin protective wipes? And skin protective wipes are not always needed. Normally, if someone has healthy peristomal skin and the barrier is sticking pretty well, we normally don't recommend these little wipes that leave a dry protective layer on the skin, because as a matter of fact, in some cases, they actually may interfere with barrier adhesion. On the contrary, in some cases, people find that the barrier may stick better. So it really is a very individual choice. And if you have questions about that, of course, contact your NSWOC nurse for that. Pressure ulcers or a pressure injury is really a injury to the skin, where the skin has actually now kind of worn away due to something called pressure, and persistent pressure. Too much pressure can cause skin damage. And in this case, this was skin damage related to someone wearing an ostomy belt, but the ostomy belt was really tight, and they were wearing a convex ostomy barrier, and that's the barrier with the ring. So what was happening was the ostomy belt was really pulling in the barrier and putting a lot of force to the peristomal skin. And unfortunately, it was so much force that it caused some skin damage and a bit of a crater around, a little skin damage that had some depth to it around the ostomy. And in this case, an NSWOC or other healthcare professionals really needed to address this situation, because there is now, quite extensive skin damage. And in some cases, powder will not be adequate to help heal or address this. In some cases, certain types of dressings are needed under the guidance of the NSWOC nurse or other healthcare professional. It's not uncommon for some people to get fungal rashes, especially in the hot summer months, when we're sweating. We know that the barrier material is meant to absorb small amounts of moisture, but we do know that in some climates, or in some situations, we may tend to sweat a lot more than others. And the problem with that is that keep in mind the barrier, has to stay on the skin. It's somewhat breathable and kind of absorb moisture, but when there's an overwhelming amount of fluid, even the moisture that's emitted from the skin, which is normal in many cases, that may lead to an overgrowth of fungus, which is normally found, on our body in very small quantities. If we're healthy and our immune system is working well, normally we can fight off bacteria and fungus and other viruses. but in certain situations, the fungus may overgrow, especially under the barrier, and this will cause a reddened area with what we call pinpoint, like red kind of dots around. And sometimes the dots have a little pustule or a whitish area in this. And if it's a fungal rash, your NSWOC nurse or healthcare professional may recommend an antifungal powder to be applied under the barrier, and that can be obtained usually with a prescription, at the pharmacy. And in some cases, when the rash is very, very large and extensive and really becoming a problem, in rare cases, antifungal pills may be prescribed, but that's done by the healthcare professional. Folliculitis occurs when there's hair follicles or hair around the ostomy on the skin, which can be normal, especially in men. When there's hair around the stoma, and it needs to be removed because it can interfere with barrier adhesion and be very painful when we remove the barrier, because it pulls on the hair and actually causes a little bit of irritation in itself, and it's certainly painful to some people. It's always advised that one clip the hair, such as with an electric clipper, a small electric clipper that can be used, let's say, for trimming a beard versus using a razor. If someone uses a razor, there's two challenges. One may, if slips and it touches the side of the stoma, it may cause injury and bleeding to the stoma. And also, if one uses a razor, it cuts the hair a little too short and one may get ingrown hair. So it's best to trim the hair and keep it short with a trimmer. If that occurs, sometimes the NSWOC nurse or your healthcare professional may advise of things to do, like some type of antibiotic type agent to help address that if it's quite severe or problematic. In very rare cases, and this is the last case of a peristomal skin complication that we'll do before we finish up in a minute, is something called allergic contact dermatitis. And this is when there's actually the redness or irritation is really caused by an ingredient in the barrier. And that can be, it's very rare actually, and it happens very, very rarely. Some people, when they see redness, they immediately think, oh, I'm allergic to something in the product or something I'm using. But it's true allergies or sensitivities are actually very, very rare. And if an allergy is suspected, it usually will have an effect on all of the skin that's in contact with the barrier. For example, you typically won't see just a little bit of redness under the barrier. You'll see an even redness under some of the material that's being used, whether it's inside or the outside of the barrier or a different component. One can even be allergic in rare cases to anything that touches the skin. So if you're seeing this type of redness and it's an even redness, it's not going away, absolutely contact your NSWOC nurse or healthcare professional to get that looked after. So I think what we've done today is we've looked at factors that affect the health of the skin under the ostomy barrier. We've looked at different types of peristomal complications and things we can do to manage them. But keep in mind, prevention is the best course of action, because once a peristomal skin complication starts, it is not easy to resolve. And lastly, we've discussed strategies to prevent and manage these complications. With that in mind, I want to thank Ostomy Society Canada for having me present tonight. And above all, I'd like to thank everyone who is watching today for attending this. I've dedicated, pretty much my whole career to working with people with challenges or certain medical conditions, such as areas of continence wound or having an ostomy, and it's been very rewarding for me. So thank you so much for attending tonight, and I'll pass it over to Troy.
Thanks so much, Tarik. That was an amazing presentation and definitely very helpful to have gone through each of those slides. I know quite a few of the questions that we got that came in were hopefully answered, and or at least gave some good information right off the bat. But I do have some for you for ready to go here. So you had mentioned, or I guess a lot of the questions here are revolving around treating the peristomal skin after we've already seen a pattern of redness and stuff like that here. We have some questions talking about the use of creams. People have heard about potentially an urban legend, or whether there's fact behind the use of Head and Shoulders as a cleaning agent. Have you heard of any creams or anything like that which would help with damaged skin around the peristomal area? And could you comment on the Head and Shoulders, whether Head and Shoulders is something that has been used before? Is there any science that goes behind that, or is that more of an urban legend?
I'm not aware of anything that can be helpful of Head and Shoulders, to be honest with you. I can tell you that for prevention, the best thing to prevent any problems if your skin is intact is simply removing the barrier, in a way that you avoid skin trauma or injury, and making sure the opening is correct and applying it in the manner that we saw. There are different kind of barriers and accessory type products that can be used, for uneven contours or dips or creases. So you really want to prevent it. But if the skin is becoming red, one of the challenges is if you put anything that is an ointment or a lotion or a cream, it absolutely will interfere with barrier adhesion. So what happens is if one, let's say, would put Head and Shoulders on and even kind of massage it into the skin, when you apply the skin barrier, there's two challenges here. The skin is now a bit moist, so the barrier likely will not adhere as well. And two, products like Head and Shoulders are used for temporary, to clean the hair. And they're probably not intended to be in constant contact with the skin under something that is covering it, such as an ostomy barrier. So I would strongly advise not to use any creams, lotions, or ointments, without specifically being told to do by your healthcare professional. As a matter of fact, when there's skin breakdown, the product of choice, especially if it's minor skin breakdown, is usually ostomy powder, because it's dry. You apply the ostomy ostomy powder onto the broken skin, remove the excess, and you'll see the powder sticks to the broken skin, and then reapply the barrier. And that powder does two things. It helps absorb the excess moisture and creates a dry surface area for the barrier to stick onto. Thank you, Troy.
Perfect, thank you. And I'm going to talk about moisture for a quick second here. And we had a question that actually recently came in. We had people asking about showering with their skin barrier or pouch on. Should they be concerned about that? They haven't seen any redness at all, but can you talk a little bit about preventing any sort of moisture-related skin damage? And showering, is it something you should be concerned about, or is that completely fine?
In general, and I'll just generalize it to all ostomy product companies, is that the ostomy barriers in the pouching system are pretty much waterproof. So if they're applied in a way that gets a good seal, and the pouch, if it's a two-piece system, is applied to the barrier, then there's absolutely no problem hopping into the shower. One thing you may note is when you get out of the shower, the pouch may be a little moist, and you can pat dry it, to remove the excess moisture. And if you're using a barrier that has a fabric type cover, just pat dry it, and that's usually sufficient. If one is taking a bath, let's say, and likes taking their baths for a prolonged period every day, honestly, it may decrease the wear time, by a day or so. So that's really individual. I know people who have hot tubs and go swimming, and there's absolutely no problem in doing that. I know of people who have an ostomy, and I used to see them when I was in clinical practice, who have hot tubs or saunas, and they'd go into their hot tub, for half an hour, a day, and they would just say, hey, you know what, I changed my barrier maybe a little bit more frequently, but I don't have any problem with my skin, I don't have any leakage, and it works well. So the simple answer is yes, you can take a shower and also go swimming or in a hot tub.
Perfect. All right, well, thank you. Another question here, and I think you briefly touched on this before, but someone was asking about the frequency of changing their appliance if they're already going through some, if they've had some skin damage as well. If the skin is irritated at all, is it better to change their flange more often or less often, or is there anything you can comment on about the frequency of changing when you're going through some of that skin irritation?
That's an excellent question, Troy. Thank you. It's a bit of a fine balance. If you have skin irritation and there's persistent leakage, one of the challenges is you're just going to have to change it more often. And I honestly remember having some people who had to change their barrier 2-3 times a day because there was persistent leakage. But if we're able to choose a barrier and the right accessories to, increase the wear time to a reasonable wear time, even with skin irritation, that will be helpful because it'll give the skin a bit of a chance to start healing. For example, if there's skin breakdown and one is using powder, and before the skin breakdown, they were able to change their barrier every, let's say, 4 or 5 days. Well, in this case, you may have to change it more often, every 3 days, let's say, and that really is very dependent on everyone. But what I encourage you to do is change it more frequently and look at your skin. Is your skin getting better? Well, if your skin is getting better and you're able to do 3 days, change it every 3 days until the skin clears up. And once it's all healthy, you can try going back to your regular wear time of, let's say, 4 or 5 days. Again, it's very individual, but an excellent question.
Thank you. I'm going to move to this question here. And this one is more specific here. There are a couple people who are talking about having a scar or a previous hole from surgery that's near the stoma, and they're talking about how they can prevent leaks that come through there if they have an ileostomy with liquid output. So if they have a kind of an uneven area, or if there's especially like a hole or a scar that has kind of a groove, I guess, closer to the stoma. Have you come into that case before? Is there something you would recommend?
Yeah, absolutely. And that's a great question, Troy, especially since we're seeing more and more people having, an ileostomy type surgery being done, number one, and two, more temporary ileostomies, so more loop ostomies, which are a bit more, challenging to get a good seal, in some cases. What we can do is two things. One, if someone has an ileostomy and the output is always liquid, you need to get in touch with your healthcare professional, your NSWOC nurse, to see, what changes can be made, let's say to the diet or using some type of medication to thicken the bowel movement so it's pasty, not liquidy. That in itself will probably help decrease leakage just inherently. Secondly, if you have dips, folds, or creases, do the following. Ensure that you're sitting up or maybe standing up. Sit up, remove the appliance, and then you can take your hand, pull the skin upward a little, very, very gently, and then take a look at the peristomal skin. See where these dips, creases, and folds are. And essentially, on the back of the ostomy barrier, you have to kind of build up the material to perfectly fit all of those dips and creases. Again, when you're changing and assessing the peristomal skin in your ostomy when you're in a sitting position, and when you're applying the barrier, you're in a sitting position, again, pulling that skin upward gently in most cases. And doing that will help with leakage, that is occurring in these folds or dips. Again, consult your NSWOC nurse because they know the products and the different kinds of materials that can be optimal for different types of folds and different types of depths.
Thank you. And I think we have time for maybe 2 more questions here. So one of the next question I have is talking about whether, do you know of any cases where the various chemicals that might be used in wafers and in the adhesive removers might cause skin issues? Someone was just asking about that.
It's an excellent question. I mean, typically ostomy barriers and the material that is specifically sold for use, for the use for an ostomy, they are tested and these are health, these are medical, what we call medical device products under Health Canada. So they do have to go through some degree of testing to ensure that they're fairly safe to use on skin and tend not to have things that typically cause problems in skin. So the answer is the products that are sold through ostomy companies that specifically make the products, are generally are safe to use. However, that being said, any product can cause irritation such as a sensitivity or in the rare case an allergy. And we know that because look at food allergies. People are allergic to different kind of foods. Even people are allergic to things that they touch. For example, some people will be allergic to certain types of soaps that they use to wash their clothes. So that being said, if you have any redness or persistent irritation, it's really recommended you start off by going to see your NSWOC nurse. And when you do that, go bring all your products that you're using, and that will help your NSWOC nurse take a look at them and see really what's causing that redness or irritation.
Thank you. And maybe we have time for one more question here. So this one, and this is talking about when you're going to, I know you mentioned already, it's very important to make sure that the size that you're cutting out is fitting well to the stoma here. This person was asking about, they're saying that they are worried that when they do cut it close to the stoma, they do see a bit of blood on the first day of every new flange. Flange is a bit of they're wondering if the flange is sharp enough to cause actual kind of laceration or cutting, if it is too close to the stoma itself. Have you commented that issue? Is that something to be worried about?
It's a really good question. I mean, typically, if someone removes their ostomy barrier and they're let's say washing the skin with a white face cloth, what may happen is you may see, you know, one little drop or two little drops of blood, and that's generally considered, you know, if it's very light and small, you know, normal. If you see persistent bleeding or any sign of injury on the side of the stoma, it's really important to reassess the size of the barrier and how you're applying it too, you know, looking at the proper application technique that we've already gone through and ensuring that the size of the opening, the size and the shape really fits snugly around the stoma to protect the peristomal skin, but doesn't dig into the edges of the stoma. So that's in general. If you have a persistent type of bleeding like that, it's really important to contact your healthcare professional and honestly, ideally, your NSWOC nurse.
Amazing. Well, thank you so much, Tarik. And I know we're coming to the end of our presentation here. So again, we really appreciate you taking the time today to answer some of the questions and to take us through this phenomenal presentation. For everybody in the audience here, I just wanted to let everyone know that you will be able to access this video as a recording on our ostomycanada.ca/webinars website. So if there's someone that you know who'd be interested in this topic, or if you want to go back and watch some of this, please feel free to do so. We're going to be having our next national webinar on January 18th in 2023, and that's going to be on the topic of the disability tax credit. And we're really excited to have Rosemary Hill, who's an NSWOC in BC, come and present along with Ann Durkee, who is the chair of our board of directors for Ostomy Canada Society. So we really encourage you to stay tuned for that announcement and to register as well. And so, Tarik, I'm just going to thank you one more time. We sincerely appreciate you taking the time today. I can't wait to hopefully partner with you again in the future, and I will be able to put on another form of education with Ostomy Canada Society.
Thank you.
Alrighty, and thank you to Yasser, who's behind the scenes, making sure that our webinars run very smoothly. And to everybody else in the audience, we hope to see you soon and have a great rest of the evening. Thanks, everyone.